CHEAR Seminar for the year. So this is great. And we have Dr. Brett Anderson with us. So quickly, I'm going to introduce you. And then after that, Dr. Anderson, you can move forward with your talk. So Dr. Brett Anderson is the Florence Irving Associate Professor in the Division of Pediatric Cardiology at Columbia University Irving Medical Center, the Director of Outcomes and Quality for the Pediatric Heart Center, the Director of the Pediatric Cardiovascular Clinical Research Corps, the Director of Columbia University Interdisciplinary MISC Follow-Up Program, and an NIH-funded health services researcher. Dr. Anderson's research focuses on the linkage and integration of large data sets and the application of econometric modeling for the purposes of identifying modifiable drivers of outcomes, values, and health inequities associated with the management of pediatric heart disease. She has examined the effects of provider characteristics, surgical timing, and social determinants of health. She is the director of the Columbia University MISC Interdisciplinary Follow-Up Program, the Director of Outcomes and Quality for the Pediatric Heart Center, and the founder and director of the New York State Congenital Heart Surgery Collaborative for Longitudinal Outcomes and Utilization of Resources, which is an interdisciplinary collaborative that brings together leadership and data from all congenital heart centers in the New York State, health services researchers, and the Department of Health to examine etiologies of health inequities and plan for pragmatic interventions. So Dr. Anderson, I'll now turn it over to you, and we look forward to hearing your talk.
Fantastic, thank you. Well, I am really honored to get to talk to you all today. I have long admired the work that comes out of your group and learned a lot from folks back from Justin Berkmeyer and John Berkmeyer and Justin Dimmick, Cal Chua, Katie Bates, Sarah Pasquale, lots of you. So the way I'd like to give this talk is to do it in some sense as a work in progress. And so if anyone is able to come on camera, I don't care if they're kids or dogs or something in the background, and feel free to interrupt me as I talk and ask questions. And it's not as, the world of Zoom is weird, but hopefully it'll make it a little more interesting and engaging for all of you. All right, so with that, this is me. You got a long introduction, and these are my disclosures. And my only other disclosure is that I am a huge proponent of collaboration. I'm a proponent of sharing data, sharing code, and sharing brains. And I think that with that, we can really not only increase our productivity, but our creativity and our ability to change care. All right, so as mentioned, I'm a pediatric cardiologist, but I really think of congenital heart defects as an example of severe chronic disease. So congenital heart defects are common. We all say they affect 1% of live births. The truth is only 1% of those go on to cardiac surgery. A lot of them are pretty minor, but it's the most common birth defect affecting children in the United States. It has high acute mortality, high resource utilization, and these kids have long-term morbidity. So one of the issues for us as researchers in this space is that long-term data are very limited. So the power of single centers studies are limited because the diseases that we study are extremely heterogeneous. There are over 200 different distinct diagnoses, procedures, and procedure subtypes. Multi-center data are often siloed. They either sit in procedural-based registries or individual investigations. And administrative data are often thought to lack clinical precision. And the issue with existing cost data is that it is often relied on inpatient costs and cost to charge ratio-based costs, which are not actually measures of healthcare expenditures or dollars that actually change hands. So several years ago now, the American College of Cardiology, the American Heart Association, US Congress, and the CDC all came out and said that longitudinal follow-up and understanding of expenditures for congenital heart patients are top research and patient care priorities. One of the other things we know is that there are significant health inequities. So this is true across all spaces, but we have looked at it in particular for patients after cardiac surgery, and have shown that outcomes are worse for minorities and children from lower income neighborhoods and families on Medicaid. So this is some work done by Kayla Lopez, she actually looked at both neonates and adults. This is her work on infant mortality, showing significantly higher infant mortality for Black and non-Hispanic Black and Hispanic children as compared to white children. That really has not changed over the last several decades. This is additional work looking at social economic indicators, 0 being the most disadvantaged decile, and looked at infant survival for children with congenital heart disease, and demonstrated an 11% increase in mortality from children from the most disadvantaged neighborhoods. So access. How do we get better? What do we do? So one of the questions has been access. This is a study that came out of some folks at NHLBI and showed that there was a 28% decrease in mortality for kids living near US News and World Report designated top 50 centers. Now, Sarah Pasquale and I can talk to you ad nauseum about the issues with these measures, but the point is that even with maybe not the best designations for quality, there were significant improvements in mortality if you live nearby. Now, this is some work done by a mentee of mine that I shamelessly stole from Cal. So Joyce Wu is a pediatric cardiologist now in Chicago. And Kao Chua and I jointly mentored her on this project, looking at the location of congenital heart centers across the United States. We found that there are 7 states with average distances greater than 75 miles to a congenital heart center for existing patients undergoing congenital heart surgery. All right, so how do we put these pieces together, right? So we say, it's worse if you live far away. It's worse if you're low income. It's worse if you're a minority. It's worse if you live in a low income neighborhood. This is some work we did now several years ago, looking at the effects of neighborhood after we controlled for the effects of race and ethnicity, insurance type, and the hospital in which you were operated. Because in our field, the first answer that everyone says is, well, it's all just a question of, do you get to the right center? So we showed that being from a low-income neighborhood was associated with an 18% increase in the odds of acute mortality after you controlled for all these other factors, a 7% increase in length of stay after initial hospitalization, and somewhere there is, and a 7% increase in resource utilization. Further, we found that if you were of non-Hispanic Black race, it was associated with a 23% increase in mortality after controlling for these other factors, and being on Medicaid was associated with a 15% increase in mortality after controlling for these other factors. Yeah, someone, did you raise a hand? Did I see a hand raised, Melinda, or were you just thinking? All right, just thinking. All right. Again, increases in length of stay, increases and increases in resource utilization. All right. So we have, in my team, been spending a lot of time thinking about targets for intervention. So thinking about what are the mechanisms through which access might mediate the effects of social determinants of health across the lifespan. And we've been thinking about this across multiple domains. So wondering, is it the prenatal space? Is it where you deliver? Is it your pediatrician, your cardiologist? Is it your surgeon? What can we do? Where can we target to make things better? All right, so the way we've gone about this was first to establish a population-based mechanism for longitudinal assessment of outcomes, resource utilization, and expenditures. We then needed to define the longitudinal outcomes, expenditures, and resource utilization, and then moved on to testing dimensions of healthcare access as modifiable mediators of health inequities. Ultimately, our goal is to take this information. We have partnered with the New York State Department of Health, and our goal is to use this to shape programs and policies to address inequities.
I have a quick question.
Yeah.
When you're using the term access,
Yeah.
are you meaning availability or are you using that as a proxy for utilization?
So this is access is a really tricky and interesting question. And we have actually been thinking about it across multiple domains. So, you know, it is not only, and I'll get into some of this in a minute, but it's not only just, are there available providers? If you're talking about congenital heart surgery and cardiologists, really the question about availability is just whether or not, you know, just how far away you live, right? It's a distance question because the providers exist. They might just be really far away. And if you roll into our ER with congenital heart disease, doesn't matter if you don't have any insurance, we're going to operate on you. Now, whether or not you can get good longitudinal care is a different question. So I will go into sort of some of our ways in which we're breaking down access, thinking about not just are there providers, but what's the quality of these providers, and how are patients using them.
So utilization, you're putting under the concept of access.
Sometimes where you're going with that for people who have not spent as much time is when you think about utilization, there's a proper use and improper use. And so sometimes increased utilization is good. Sometimes increased utilization is bad. And if you're providing poor care, then patients may be going to the emergency room a lot. And that is high utilization, but bad care. So we've been thinking through it sort of from multiple fronts. Is that what you're thinking and where you're wondering?
I'm just trying to understand from 2 slides ago what the goal, what you're really what one. Well, there are mechanisms through which access might mediate effects. So I wanted to know what, since that seems like crucial to your thing.
Yeah. Let's go here. Hold on. We'll skip ahead then, and then we'll go back. Flying. Hang on.
That's all right. I didn't mean to throw off everything.
No, that's okay. So these are the types of questions we're thinking about in terms of access. So, no, you know what? I'm going to excuse me. I'm going to hold your question, if that's all right.
That's fine.
Okay. Let's go back here. All right. So the way we started down this road is we had an opportunity. So it's weird to call Medicaid an opportunity, but we recognize that about 50% of kids with congenital heart disease are on Medicaid. And as we've already talked about, these kids are at increased risk. It's also for kids, unlike for adults, a relatively stable form of insurance longitudinally. Medicaid also provides detailed information across time and across institutions on all billed services, including inpatient, outpatient, emergency room visits, pharmacy, rehab, home health, early intervention, education services. It's got, well, so we have direct access to state Medicaid data. So we have patient addresses, which allows us to do very detailed geolocation. And based on Medicaid family ID, we are able to pair mothers and infants to examine prenatal care. All right, so how did I have this opportunity? Well, this woman, for anyone who doesn't know, is Sherry Gleed. She is the Dean of the NYU Wagner Graduate School of Public Service. She leads the Health Evaluation Analytics Laboratory, and I was fortunate enough to have had her be one of my long-term mentors. NYU Wagner has had a long partnership with the New York State Department of Health, and they have helped the Department of Health to examine the effects of all sorts of different programs and policies on health outcomes by linking these data to New York State Medicaid claims. And as I mentioned, these data that they have, unlike, say, Medicaid Max, have direct patient identifiers. But as Sarah Pasquale has shown, sometimes the granular clinical detail are lacking in administrative data. And there are some challenges, we shall say, in accessing national and state registry data that do have these clinical detail. So how did we do this? So we did this by creating the New York State Congenital Heart Surgery Collaborative for Longitudinal Outcomes and Utilization of Resources. That's a mouthful, so we call it CHS-COLOUR. And we brought together 10 of the 11 congenital heart surgical centers with certificates of need to perform congenital heart surgery across New York State. We linked them with our partners at the Department of Health, and we got everybody to send us their data. So we have clinical registry data from New York State and STS that date back to the 1990s. These have granular clinical detail and diagnoses, procedures, comorbidities. We have New York State Medicaid data starting in 2006. And we are sent these data on a quarterly basis. As Medicaid releases their sort of updates, cleans, and releases their data, and then as each center submits their data to the state and national registries, they take a cut of those data and send them to us. We've then further linked those data with Census Bureau and social programming data to look at social determinants of health and social services, and then are using, sorry, I didn't put in here yet, and we recently linked to the National Death Index, and we are using these to examine longitudinal follow-up. All right, so from our initial registry of 14,000 eligible cases, we had about 7,000 Medicaid matches for an 89% Medicaid match rate. We found about another 2,000 had partial matches, so they had no operative claim, but they were covered by Medicaid either before or after the operation itself. So in total, that gave us some information on about 67% of total cases performed in New York State. We did manual validation, found greater than 99.9% of these cases were true matches. And then as we looked at it and we used various iterations to require sort of duration of Medicaid enrollment in order to say that we have longitudinal follow-up. And if we require near continuous enrollment, we had approximately 75% of longitudinal follow-up at 5 years and 65% at 10 years. All right, so what have we done with these data? Well, first, we developed and validated a risk stratification tool for congenital heart surgery that can be used in ICD-10 administrative data. We've called this RACS-2. Well, why do we need this? So as I said, there are over 200 different congenital heart procedures and sub-procedures, and the billing coding is just frankly not very good for these. So prior risk models, RACS-1 was developed by some folks sort of around the country, but led by folks up at Boston. It was a consensus-based model. Then that was superseded by a registry-based model that was empirically derived, referred to as the STAT model, done by the Society of Thoracic Surgeons using their clinical registry data that's now in CHS-COLOUR. Well, Sarah Pasquale, some number of years ago now, linked administrative data looking at RACS-1 and STS clinical registry data looking at STAT categories. And basically, she showed that the administrative data was really not very sensitive. And further, there were whoppingly shocking differences in relative mortality. Further, well, ICD-9 went by the wayside in October of 2015, so the RACS-1 model that existed could not be used anymore in administrative billing data since that time, and no one had updated it for ICD-10. So this is Philip Allen. He was a medical student and master's student, now resident in cardiothoracic surgery in Boston, who did his master's thesis with me, and he developed the RACS-2 algorithm. So he compared it to the algorithm, the STAT risk stratification model in clinical registry data in our linked CHS-COLOUR database, and found that RACS-2 had greater than 99% sensitivity for case volumes, and further that it explained greater than 80% of variation in outcomes, which was as good or better than the existing STAT clinical registry model. For anyone who is interested, we have made these code publicly available. Anyone just sends me an email and we send you the code and a sort of a guidebook to go along with it. All right, so then we said objective 2 was to describe longitudinal outcomes and resource utilization. So we had to think about mortality. Think about operative mortality, longitudinal mortality beyond the initial operation, and then expenditures, thinking about total Medicaid payments and healthcare utilization. We focused on inpatient, primary care, emergency room, and subspecialist visits. In other work, we've now also looked at medication utilization as a proxy for chronic disease burden across the lifespan. All right, and we looked at various risk factors. All right, let's go into. For this project, we took a cohort of all New York State patients undergoing initial congenital heart operation in our linked cohort from 2006 to 2018. We actually did this on purpose just to stop right before the pandemic. And we required all patients to have at least 1 year of nearly continuous Medicaid enrollment or to have died during this period. We then took matched non-cardiac surgical Medicaid enrollees. So these are kids on New York State Medicaid who never underwent congenital heart surgery. These are our healthy controls. And we matched them on date of birth, age at Medicaid enrollment, duration of enrollment, and county. And then we compared mortality expenditures and healthcare utilizations to New York State non-cardiac surgical Medicaid enrolled children. Within cardiac, the cardiac patient population, we then also looked at risk prediction, understanding which factors increased mortality, healthcare utilization, and expenditures. Okay, so we used sort of standard models to begin with, but then there were some sort of important considerations that go along with this that are not so simple. So one of the things is that in using Medicaid data, it is not a simple cross-sectional cohort. So we had to consider the fact that the duration of enrollment depended on the date of operation, that Medicaid enrollment duration is non-random. So we had to, one, censor for disenrollment, but also we had to consider expenditures and utilization, both with and without continuously enrolled patients. Because as income changes, you may disenroll. As income changes, your risk of adverse outcomes may change. And then we had to consider the fact that there were nonlinear relationships between our predictors and outcomes. So we did this by looking at 1-year mortality, and then separately 2 to 5 year mortality. We looked at it with and without operative mortality. Again, expenditures and utilization, we separated out into 1 and 2 to 5 year. And then we dealt with the issue that survivors use different healthcare resources. And so the way we dealt with that was twofold. 1, we looked at it with and without mortality. And 2, we used something called Heckman selection models, which predicates the fact that the patients entering the 2 to 5 year model will look different than those who would have entered had they not died during the first year. All right, so all of that gets us to this. We had about 5,000 children who had initial cardiac operation during the stated time period. We had basically all of them were eligible for 1 year and mortality models with an operative mortality of 4%. We then used those to look at those that died by 1 year and found about 6.4% of children died by 1 year. And then in our 2 to 5 year models, we had 3,900 kids who were eligible and found another 1.2% of these children died by 5 years.
A quick question.
Yeah.
How did you determine that they had died? Was that through clinical data, Medicaid, another option?
Yeah, so it depends on which death you were talking. So for operative mortality, so the definition of operative mortality is comes from the clinical registry data, and it is whether you died in hospital or within the first 30 days if you're discharged before 30 days. These data are obtained largely from sort of former cardiac ICU nurses who become formal clinical registry data abstractors. And these teams and the clinical teams call all patients and families to verify operative mortality. That data is pretty accurate because as we sort of alluded to with the US News and World Report comment, it is one of the major measures on which hospitals are judged. For longitudinal mortality, we then relied on Medicaid claims. And we have within Medicaid claims, now we are also linked to the National Death Index. And so we have validated mortality both within what Medicaid, who Medicaid thinks are dead, as well as who the National Death Index thinks are dead. And then if you, yeah.
Follow-up question on that. So if your patient disenrolls from Medicaid and moves to a different state, can you observe their mortality? I think the answer is no.
In the National Death Index, yes. But in this study, we did not. In this study, we called them disenrolled and then pretended they didn't exist.
Right.
The main reason there is that we didn't have other outcomes for them if they were moving to a different state. So we required them to be continuously enrolled or nearly continuously enrolled for most of these particular analyses. For some of our other work, we have relied on the National Death Index when we didn't. So we have some studies that are undergoing, recently presented at PAS. We were looking at the impacts of adding social determinants of health to clinical risk models in congenital heart surgery. And for those, we didn't specifically rely on the Medicaid data. So then we used the National Death Index data to determine mortality. And then it was wherever you were across the United States. In those cases, actually, then we just had to be sure that we excluded our international patients for whom we would not have national death index data. All right. So this, I'm going to walk you through it. It otherwise looks kind of overwhelming. But what this slide is looking at is Medicaid expenditures. The big graph, these are for kids with congenital heart disease, or more specifically, kids who undergo congenital heart surgery. This little dashed line is the comparator for the top of this graph up here for kids without congenital heart surgery. So you'll see kids with congenital heart surgery, if you exclude their initial surgery, they spend about Medicaid spends about $62,000 in their first year of life versus about $6,000 for kids who don't undergo cardiac surgery. And of note, this is not including the initial operation. If you include the initial operation, you're talking about $186,000 in the first year. The bulk of these expenditures are on inpatient services. So 63% in the first year, but still 39% in year 2 and 35% out in year 5. Chronic care makes up the second biggest bucket. This for most patients means either home health services or admissions to rehabilitation services. And one of the things you'll notice is that this is still 30% of expenditures out at 5 years. So this really represents a small fraction of the population, but very high resource users. Medication prescriptions are another large bundle. One of the things that actually Joyce Wu, Cow's former mentee, stolen by me, has looked at is in the early years, probably no surprise to any of the pediatricians in the audience, this is Synagis. But after year 1, obviously it's not Synagis and medication burden remains quite high. Educational services. So this, for the most part, in the first 5 years, you're talking about early intervention here. This is a large bucket of expenditures for Medicaid. I'm going to go back. I didn't point it out, but you will notice everyone talks about emergency room visits. Emergency room visits represent less than 1% of healthcare expenditures for kids with congenital heart surgery. And if you look up here, it's really less than 3–4% of expenditures for all kids on Medicaid.
Right. Do you have any sense of what percentage of the total expenditures are attributable to the congenital heart condition itself versus other comorbidities?
Yeah,
If possible, it's really a hard question.
It's hard to tease out. It's a really interesting question. So Joyce looked at that a lot in her medications paper that has actually just been accepted into JAC. So hopefully you will see it shortly. But one of the things that she saw there, and the reason we use medication is sort of it's an indication of how much of the chronic disease burden is cardiac and how much is not. And there is a bulk that is cardiac, but there's a whole lot of other stuff that's happening. What I will say is these inpatient expenditures, a lot of that is cardiac. So a lot of these kids undergo repeat hospitalizations, repeat surgeries, repeat cardiac catheterizations, and admissions for heart failure and other cardiac complications.
And how did you deal with the capitated payments? Like, it seems like is everything fee for service?
No. So we actually have sort of a complicated algorithm because increasingly you are correct, our New York State Medicaid is using managed care plans. And so what we do is we take the fee for service payments and we basically use the managed care utilization and we back calculate fee for service equivalents. All right, so this looks at inpatient admission. So you'll see kids After the initial hospitalization, you're talking about 2 admissions in the first year, a total of 31 days. But even out at 5 years, about 0.3 admissions per kid per year. Versus this is the non-cardiac kids in their first year of life, and you're talking 2 inpatient days. Largely that's for birth. ER visits, interestingly, as you sort of saw in the expenditures graph, not all that different than the rest of the Medicaid population. Primary care visits, however, were different. So in the first year, talking 11 visits on average, 5 visits per year per kid in year 5. Versus comparators, you're talking about 7 visits in the first year. These are, your standard well-child checks. You've got to go in at 2 weeks, 2 months, 4 months. I don't do general pediatrics anymore. I don't remember the schedule, but something like that. But at 5 years, they're going in 3 to 4 times a year versus 5 times a year for congenital heart kids. And subspecialist visits is where things really depart. So at this point in 2018, you see that kids in their first year of life are going for about 6 subspecialist visits versus 0.7 visits per year in the comparator group. All right, so let's talk about predictors of mortality, expenditure, and healthcare utilization. In particular, we focused on looking at Hispanic ethnicity and Black race. And one of the things you see, oops, sorry, went too fast. So operative mortality or confidence intervals here for this project were particularly large. But this is generally, the point estimates are generally what's been shown in the literature. 5-year mortalities we're ranging in here. Point estimates are around a 30% increase in the odds of 5-year mortality. If you exclude operative deaths, you see sort of similar odds ratios. All right, this was the thing in the slide that I was excited to show you. So here's the interesting thing. Expenditures are pretty similar. Admissions, this is our comparator here is non-Hispanic white. Admissions, maybe they're up a little bit. Here's where things get really interesting. So primary care visits for Hispanic and non-Hispanic Black children are about 30% lower, both in the first year and 2 to 5 years after cardiac surgery than non-Hispanic white kids. And emergency room visits are about 40% higher for Hispanic and non-Hispanic Black kids than they are for non-Hispanic white children. All right, so now this gets to the question that someone was asking earlier. So our whole idea is let's think about access as mediators of equity. What are we talking about? All right, so sorry, this is a public service announcement before I get into there. This we published last week in Health Affairs. Part of our going down this road, we had to look at various measures of social determinants of health and which was the best one to use to understand outcomes in congenital heart surgery, particularly as it applies to New York State. Public service announcement is, as we looked at the area deprivation index, as it has been popularized by the Neighborhood Atlas, it's publicly available now on their website. It turns out that when they updated the ADI, even though it's supposed to include 17 different measures, the current version is driven by variables that are characterized in dollar values. Because they did not standardize the 17 measures before they put them into this particular version of the ADI. And so when you use the Neighborhood Atlas ADI, essentially what you are using is median home value. The original ADI did not have this issue, but the current publicly available version does. So just as anyone who is using the ADI, just throwing this out there as a public service announcement. All right, so now we get to healthcare healthcare access. So Joyce Wu, so she is a fetal cardiologist at Lurie Children's now. She linked our prenatal care data from mothers on Medicaid to their infants. So she took all infants who underwent cardiac surgery at less than 60 days of age between 2006 and 2018. And linked to women between 15 and 45 years of age who were continuously enrolled in Medicaid during the pregnancy window, who had the same Medicaid family ID as these infants. She was able to match 88% of infants to mothers using infant date of birth and obstetric claim for delivery on the same day. One of the things that she found is that lots of people were getting either a level 2 ultrasound or a fetal echo or both, but nearly a quarter of kids underwent congenital heart surgery in the first 60 days of life had neither. So these are kids who did not have a prenatal scan to identify their congenital heart surgery or disease that required surgery in the first 60 days of life. All right, so she's further looking then at the timing and the percentage of prenatal visits timely completed. She's looking where the fetal echoes or level 2 ultrasounds were performed and the number of these that are performed. And then using these to look at birth, whether or not this predicts birth at a cardiac center and outcomes.
Quick question.
Yeah.
What was the time frame for that? Like how many years was that? Over how many years?
2006 to 2018.
So I was just curious, and I hypothesized there may have been a difference over time. Like, were there more ultrasounds done by 2018 compared to the cohort in 2006? Or was this a relatively equally distributed phenomenon across the years?
As I recall, although Dr. Wu would remember the details better, and she actually is working, she has this submitted, currently under review to take this sort of to the next level under a K-23. But as I recall, it increased slightly over time, but not nearly as much as you would have thought or wanted.
Thank you.
Mm-hmm. All right, so birth. We're then thinking about questions as, these are sort of the ways in which we are defining access. And we've been putting together these measures. And as I talk through these measures, if anyone has ideas, thoughts, things we're not considering, jump up and shout, because we are open to your ideas. We are looking at prenatal center level of designation. So New York State designates centers based on their NICU capabilities. And then we further added in whether or not they are centers that can perform cardiac surgery. We are looking at the timing to the first postnatal echo. Unfortunately, in the claims, we are only able to see that if they are discharged prior to their cardiac surgery, but if they undergo cardiac surgery during their initial birth admission, we don't have a date on that echo. We will just see that they underwent cardiac surgery at that time.
How often is each of those things the case?
Yeah, so 30% of kids with congenital heart disease undergo their first surgery in the first 60 days of life. 50% undergo it during the first year of life. And the next 50% undergo their initial cardiac surgery after the first year of life.
Is that dependent on diagnosis?
Yes.
Okay.
I mean, with some differences for like things gone really wrong.
Yep.
All right, so thinking about the surgery itself. So one of the things someone talked about access. So thinking about the distance As I mentioned, Dr. Wu's done a lot of work thinking about the distance to cardiac surgical centers. I would say in New York State, similar to in Michigan, they are not evenly distributed across the state. So we have 5 in New York City. Actually, one is no longer performing surgeries. We have 4 currently in New York City. The other 6 are randomly spread, but many patients have to travel over 100 miles to get to a cardiac surgical center. Looking at the timing of surgeries. So as I mentioned, we have clinical registry data for all the cases performed across the entire state. So looking at the distributions, our surgeons and centers operating on their Medicaid kids in a timely manner based on their particular diagnoses and procedures. We're looking at the volumes of the surgeons and the centers, and we're looking at the years of experience of the particular surgeons.
And all of this is stratified by diagnosis.
All of this is risk adjusted for diagnosis. Yes, the calculations of timing are the way we have done it is basically by each diagnosis, we have calculated the distribution of timing and then calculated an average of the timing distributions per surgeon and per center.
And the diagnoses, that works with the diagnoses are in fact randomly distributed across all of the centers. Is that the case? Or do some centers get more of one type of condition than another?
The latter, definitely not equally distributed across centers. This gets into sort of a question that we often debate of whether centers go into our models as fixed or random effects, because center is itself is indeed a huge player in outcomes. All right, subspecialists in particular, right now, we've been focusing just on the cardiologist. Future work hopes to look at other types of subspecialists. But here again, we've looked not just at distance and timing and volumes and experience, but also cardiologists looking at the percentage of the percentage of their patients that a pediatric cardiologist sees within 1 or 2 weeks of hospital discharge. In our world, the answer should be 100%. And looking at, and we don't know if this in fact is or is not a measure of quality, but looking at whether or not a cardiologist performs echocardiograms on the same day that they do clinic visits. So in the adult world, it has very much moved to separating these two in order to increase flow through cardiac clinics. And many pediatric cardiac centers have started to move in that direction as well. All right, and then some really interesting things we are starting to delve into on primary care versus emergency room use. So we talked about how we saw these sort of stark differences. So looking again, volume and distance, looking at association with a cardiac center, we had a whole bunch of other candidate variables. We thought we were going to look at the percentage of vaccines timely completed. We thought we were going to look at the percentage of developmental screens by pediatricians who were appropriately completed. We are in fact looking at the percentage of 30-month well child visits completed. We thought about the ambulatory to ER visit utilization. Actually, we quibble with that measure as in general, and then looked at looking at ER designations and primary care preventable visits. Well, one of the things we found, a lot of these measures are just not very good for this population. We've tested a lot of them, and so for the vaccines, for example, no one in New York State Medicaid bills for them because they're not reimbursed. They are bundled with the primary care visit. So there is no way, unless we link with vaccine registry data, to get this measure, despite the fact that it is used as an NQF measure. Developmental screenings, similarly, they're not billed for. An ambulatory to ER visit. So that's the name of the measure. And we are exploring the possibility of actually making that into the measure. So a ratio of ambulatory visits versus emergency room visits. What the actual measure is the proportion of a pediatrician's panel who go to the emergency room. And if you are a pediatrician who deals with a lot of complex kids, like kids with congenital heart disease, that measure is going to be higher for you, not because you're doing a bad job, but because you care for more complex kids. So we've thrown that measure out. And primary care preventable visits. So this is a measure that is used extensively in the adult world, actually by some of our colleagues. It was developed by John Billings at NYU Wagner. Unfortunately, a lot of the measures that are included in this calculation are things that congenital heart patients would appropriately go to the hospital for, like heart failure. So in this measure in the general population, going to the ER for heart failure is considered something that a primary care doctor should have been able to keep you out of the ER for. In our population, we've decided that just does not make sense.
Hi, Brett. This is Hal. I'm just aware of the time, and also just
This is perfect, actually.
This has really been extremely interesting, and I hope we'll have the opportunity to hear more from you with the rest about some of your other really interesting research. But unfortunately, we do have to wrap up right now.
No, it's perfect. You were actually literally on my last slide, so that is perfect.
Okay. Sorry.
If anyone has thoughts on these, we are still working through lots of these access measures and trying to understand how we really could identify ways in which we could intervene. I know a lot of you have done some similar sorts of work in different populations. And as I mentioned at the beginning, we are all about collaboration. So anyone interested in reaching out, talking, sharing ideas, and partnering, please give us a shout.
Absolutely. Thank you, Brett. This is awesome. Thanks for putting all your efforts trying to put together this awesome kind of data linkage. It's really cool.
Thanks so much.
Great work, Brett. Great to see you.
Great to see
Bye.
you too. Take care.
Also, just wanted to jump in real quick. Thank you, Dr. Anderson. We do have the survey in the chat, and if you could complete that, and we're going to put it on the screen as well, just to give us some feedback on Dr. Anderson's the presentation today. And thank you all for joining, and we look forward to future seminars.
Thank you for having me.
Bye.
Bye.
Oh, you're good.
Yeah.
Okay, ready. Whenever you're free, I don't think I should.